I'm Andrew Bennett, National Clinical Director for Musculoskeletal Conditions for NHS England and Improvement. Many thanks for taking time to listen to this podcast. Tackling the COVID-19 elective backlog represents a significant challenge. We need to make the best use of our resources whilst continuing to deliver high quality care that is safe and associated with best outcomes and experience. This strategy, supported by Getting It Right First Time, the Royal College of Emergency Medicine and the British Orthopaedic Association, to manipulate the majority of children's forearm fractures in the emergency department rather than theatre, will help free up much needed theatre resources whilst maintaining quality of care. Of course, this alone will not impact the waiting list challenge, but rapidly implementing multiple proven strategies such as this will help. If not already, it would be great for services to take this proposal forward to help with our collective challenge of reducing waiting times. I'd like to thank Fergal, James, Deborah and Jackie for sharing their expertise in this podcast. Thank you for listening.
This is a both bone forearm fracture in a child, and this is an extremely common injury which will present in numbers to any urban emergency department that sees children. This is particularly common in the summer months and represents a significant component of the workload of both the emergency department and the orthopaedic department. I want to consider a process map of two alternative scenarios. The first being very common prior to 2015-16, and an alternative which we consider to be a standard of care which we should aspire to in 2022 and beyond. It all starts with the injury, and following that, the child will be taken to an emergency department. They'll be triaged, they'll have a radiograph which will determine the anatomy of the fracture, and they'll usually be reviewed by a staff member in the emergency department. At this point, they'll be referred for orthopaedic review and often admitted for an overnight stay. Whilst this is not inevitable, it is common, particularly if there are no scheduled trauma list. The following day, they'll be starved for an unscheduled manipulation, which is often added to an overcrowded schedule. The child will require a pre-med and be prepared for surgery. Will be given a general anaesthetic, fracture manipulated and placed in a plaster cast. They'll require a period of recovery from the general anaesthetic, and depending on the time of day, this may require a second overnight stay, following which they'll be discharged. An alternative scenario, which we will describe to you in some detail, they'll still require an X-ray. At this point, the child will be recognised as a candidate for a manipulation under Entinox and diamorphine. The appropriate team will be assembled. The child will have a manipulation and a plaster cast in the department, usually in the plaster room, and they'll require a brief period of recovery. They don't require any pre-starvation, and they don't require sophisticated monitoring. They'll require a radiograph to confirm the position, and they'll be fit for discharge. The previous system can take up to 2 days, and in an efficient, coordinated alternative system, this can be reduced to 2 hours. This is of enormous benefit to the patient and their family. This is not an argument about economics. This is not an argument about convenience to medical practitioners. This is for the benefit of the patient and for their family. An unreduced fracture is extremely painful. A child who's had a fracture reduced and placed in a cast can be managed with simple oral analgesia as opposed to a splinted but unreduced fracture, which is very painful. There is the domestic disruption associated with an overnight stay. There is the organisation of childcare for siblings. There's the employment disruption for a working parent. There's prolonged starvation for the child, particularly if there's not a designated paediatric trauma list. And there's procedural anxiety associated with the whole process of attending an operating theatre for surgery. The child has to be taken to a strange environment, meet a variety of unfamiliar people, and even with well-established pathways and experienced staff, this is a substantial source of anxiety for the child. There's a potential for cancellation, particularly in busy departments, and this requires rebooting the whole system and further delays.
So, not all forearm fractures are created equal. Some are associated with high energy, a significant soft tissue injury, and complete displacement of the bone ends. This injury is very different from a low velocity injury, which has minimal soft tissue damage, where there is incomplete displacement And to our benefit, there is an intact dorsal hinge, which means that we can bend this forearm straight very easily. And when we are bending that forearm straight, we have to ask ourselves the question, is close enough good enough? And certainly it can be. In pediatrics, it depends on the age of the child. So the younger the child, the more angulation you can accept, because the fracture will heal and it will remodel. If the child is older, then you can accept less angulation because there is less growth and less time for remodeling. So with that information, we can confidently treat a minimally displaced fracture or angulated fracture with 3-point pressure above and below and at the site of the fracture. And by applying that pressure, we can push the bones into a better alignment and support them as we apply the plaster.
Because of the problem of large numbers of bent forearms being admitted to hospital for formal manipulation and plastering in theatre, in the second half of 2013, we began, with the aid of our emergency department colleagues, a process of treating this in the emergency department with intranasal diamorphine and Entonox, and we found that this analgesia mixture was extremely successful, and that in over 90% of cases, we were able to get the forearm straight such that no further procedure was ever required. And the number having formal fixation was in fact very few indeed. So we published that work in 2016, and it was quite popular amongst pediatric orthopedic colleagues, and we thought it would be adopted widely. In 2018, I became the clinical lead for GIRFT in children's orthopedics, and my investigations concentrated on many aspects, but one of them was the manipulation of the forearm and wrist in theatre, for which there was good data. And we found enormous variation between the numbers of forearm manipulations done between various hospitals. And there was in fact a 29-fold difference between the hospital doing the most and the hospital doing the least. But perhaps more usefully, we compared two similar size centres, which were both paediatric trauma centres, with equal numbers coming to the children's emergency department. And here we found a 10-fold difference in the number of formal inpatient manipulations being done, which led to a 10-fold difference in the number per 10,000 emergency department attendances, which is a metric we use to smooth the data. So why should this be? We don't really know, apart from the fact that some emergency departments have adopted this, like our own in Nottingham, and some have not. Now, the result of all this, we found that 250 weeks of operating theatre were being dedicated to manipulation of the forearm and the wrist, and that the amount being spent overall on upper limb fractures in paediatric T&O was £45 million or in excess of that. And we felt that if we could bring the level of inpatient manipulation down to that of the best performing trusts, then 80% of those operating weeks would be saved. So we have found that the system of manipulating fractures in the emergency department is extremely efficient and successful. We have not found breaks in the 4-hour wait, and we have found with repeated audits that it is very acceptable to children and their parents, and they're extremely happy with the treatment. Other people have also found that this method of analgesia is more than adequate for these manipulations in other countries as well. So this is an extremely cost-effective and acceptable treatment regime.
We performed a qualitative analysis looking at child and also parents' perspective of fraction manipulation. We focused on the management of simple closed forearm fractures. And in 2016, the department moved to using manipulation under sedation. Our inclusion criteria were children that had had a manipulation within the last 30 days in the department. So our actual injury to interview period was 7 to 21 days. And we excluded any children that had been treated for other injuries. And the age range was between 5 and 14. Regardless of any previous experience, whether the children had had a general anaesthetic in the past or not, the idea of theatre management was more emotionally distressing for both the parents and children. So the parents were nervous of any potential risks of general anaesthetic, and the children wanted to avoid going to theatre completely. Comparatively, when we looked at manipulation in the emergency department, there were some negative connotations around fentanyl and Entonox, so particularly for teenagers. There was an association with the use of NOS. Teenagers had heard about this at school and they were quite tentative to engage with the Entonox at first. Both parents and teenagers were easily reassured by speaking to the team about this beforehand, and children and parents wanted same-day treatment. Parents were saying to us that they felt that the longer the wait, the greater effect emotionally on the child, and children were saying to us that they would have lost sleep and they were quite anxious of having to return home, knowing that they then had to come back to hospital for further treatment. So that was very important to both the children and the parents. Under positive experiences, if they wanted to, particularly the younger children, they could have their parents present for the manipulation, in contrast to theatre. They felt well informed about the procedure and they had a good rapport with staff, and we know that that all leads to reduced anxiety and reassurance, and therefore overall a positive experience. The children were conscious, so they were aware of the manipulation, but they described this as a pulling or pressure sensation, and they all described it as manageable, especially due to the brief course of treatment. There was no nausea or vomiting recorded. Children described feeling a bit disorientated or even dreamlike, and actually some parents reported that their children were laughing or even singing during the manipulation, so no negative side effects were recorded. When we looked at negative experiences of treatment, we screened for lasting psychological effects. So we asked children whether they found treatment distressing at the time, and if they thought back to the experiences or had any nightmares or any negative experiences coming back to the hospital after treatment, and no negative experiences were reported. Parents were aware that staff were in training, but they were again reassured by the presence of supervision during manipulation. So overall, the majority of patient experiences were positive, which is encouraging. And we've been able to show that treatment aligns well with the expectation and values of both children and their parents. The surgical reported outcomes are positive, and the patient reported outcomes are also positive.
This led to the construction of a document called a BOAST. And a BOAST is a BOA standard. They've been published since 2008, and they're consensus-based short standard documents for a number of aspects of trauma. In March 2021, dealt specifically with the early management of the paediatric forearm fracture. And this document was produced in collaboration with the Royal College of Emergency Medicine, and between us, we tried to identify the components that were important to clinicians, whether they be from an orthopedic surgery, pediatric, or emergency medicine background. And this document has subsequently been endorsed and badged by the British Society of Children's Orthopedic Surgery and the Orthopedic Trauma Society, in addition to the Royal College of Emergency Medicine and the British Orthopedic Association. The inclusions are for skeletally immature patients seen in emergency departments following an angulated but not offended forearm fracture. Provided there remains some bony continuity, these fractures are considered to be suitable for this type of treatment. And the standard recommends that all units that manage children's forearm fractures should have locally agreed protocols to allow early definitive manipulation and casting without necessitating admission to hospital. It should occur in a location which is suitable to ensure safe practice, with monitoring and appropriate facilities for casting, managing any complications, and recovery from any medication. The manipulation itself will be done by a trained orthopedic surgeon who's competent in doing this specific manipulation in this environment. And every unit will be obliged to conduct regular multidisciplinary audits against the above standards, and in particular to monitor the rates of admission, which is one of the most useful metrics to indicate whether this procedure is both adopted and successful.
Well, thank you to all the speakers for a concise but comprehensive overview of this important BOST document and how we can integrate it across the country into ED departments. I'd like to ask some questions, if I may, addressed to all three of you. Can I ask, does this procedure cause, or the actual journey cause, pain and distress to children and their parents and the paediatric staff? If I can ask you, James, first.
Well, so I think our survey suggests that that's not the case. In fact, quite the opposite, that children and parents are extremely glad to get the arm straightened and get home, and that they are not feeling a lot of pain and distress. We've actually done the work with pain scores, and as you would expect, and so have other people, demonstrating that this kind of analgesia is more than effective for this procedure. We've gone back and asked patients who had both formal manipulation in theatre and straightening in the ED, which they preferred, and generally they preferred to have the arm straightened in the ED and go home for obvious reasons. And as far as the staff are concerned, I think engaging the ED staff is really important, but when that work is done, actually they find it extremely satisfying to treat and discharge patients with these fractures.
Thank you. And Fergal, is there a unit in Bristol which has not adopted this? Are there any further pointers with barriers within ED that have proved difficult?
Since the GIRF visit, this is changing in Bristol. It has allowed us to identify what the barriers to implementation are. There was a lot of mystery surrounding the exact definition of what was to be done, where it was to be done, and by whom. And with some local education going over with the emergency department staff, the specifics of what's being asked of everybody. Once people have got over the initial apprehension about doing this and understand what we're up to, then it tends to be adopted without much discussion. There are still barriers, there are still some issues, but they are relatively easy to overcome.
Thank you. And Deborah, any thoughts on from your experience?
I think the whole process causes pain and distress to the child and the parents. Having the fracture being in an A&E department is not normal, so it's all very anxiety inducing. But if you admit, the parents are always wondering when the next stage is, when is it going to get better, when is something going to happen? And by the time they've started wondering, if they're treated in the ED, they're home. So the anxiety and distress may still be there, but the pain can be helped with the analgesics, and it's all over in a very smooth and quick pattern. And I think that's really important.
The second question is kind of practical one. Do these children need to be starved before the manipulation takes place in the ED? James?
We don't starve people to use Entonox for any of the procedures or to give diamorphine intranasally. The reason for that is that they are awake, they have an intact gag reflex, they have control of the Entonox because they hold it themselves, so they can't really overdose. So we have not implemented any starving for any procedures we do under Entonox.
And that is one of the major advantages of using Entonox and diamorphine. There are other protocols which have evolved, but as a starting point, everyone would agree that that's a safe procedure. You don't need to be pre-starved. There's a rapid recovery from it, and it's a very efficient way of doing it.
Thank you. So my final question is, EDs are under huge pressure, particularly now post-pandemic, and the stress on trying to meet the targets, particularly the 4-hour wait and others. The pressure on trusts and physicians and health professionals is high. Can I ask, with this extended or potentially extended procedure, would patients break the 4-hour wait?
So my experience is that they don't, if they're triaged efficiently, and that basically means a bent arm is identified by the triage nurse and they're sent rapidly for X-ray and the process is instituted. My colleagues in Reading who've instituted such a protocol call it the 2-day to 2-hour protocol, because 2 days is what it took to get an MUA done under their previous system, and 2 hours is what it takes under their current system.
And I'd agree with that, James. It's a matter of just everybody understanding what's in front of them and what's required of them to make it work, rather than seeing someone in the waiting room with an obvious candidate arm, but not activating things immediately, then that may cause unnecessary delays. But if it runs smoothly and if everyone understands how the system works and what their part in it is, then it should be, if anything, it should improve 4-hour waits, because as the Reading Group have demonstrated, it's possible to get people treated before any 4-hour alarm clock goes off.
I totally agree with that. The whole pathway is efficient and effective as long as you recognise the problem and deal with it according to the protocol. So it should work really smoothly.
Space was always a thing that we had in Bristol, and also in other centres, kind of space in the ED to do procedures like this. We were thinking at one point doing kind of joint injections from our point of view as rheumatologists and things like that. But so has that been raised at all?
I think every department has its own issues. Certainly in Bristol, as you know, we have to negotiate for space. It's naive to just expect that everyone just accommodates us. I think that's part of the dialogue and part of the evolution. And the right way through it is to engage with the emergency department, clinical, managerial staff, so that this can be addressed very early in the process.
Our system works well because there is a document that everyone can follow, which is an agreed document between orthopaedic surgeons and the emergency department. And it's a living document. When we encounter problems, we edit it. But the other thing I would say is that every emergency department has somewhere where plasters are applied. And this system can generally be instituted in that place safely, efficiently, with the normal people. And actually, we avoid lots of people going to the emergency department. The emergency department nurses own the procedure, and they summon the surgeon when they want them, saying, we have an analgesic patient who needs their arm straight. And the orthopaedic registrar comes. So there are some practical difficulties for some trusts in terms of accessing the right surgeon at the right time. But for many trusts now, there's an orthopaedic surgeon who is on the floor, certainly in everywhere that has any kind of trauma input. So that's not such a huge problem.
Well, I hope you found that interesting and informative. My name is Chris Moran. I am an orthopaedic trauma surgeon from Nottingham, one of the busiest units in the country, and I really would commend this technique to you. We introduced it into Nottingham and it really transformed care for our children. One of the real issues, particularly in ED, nurses and doctors are concerned that this might be a potentially very unpleasant experience for the child. But I think I'd emphasise as a surgeon that actually going to theatre is a very unpleasant and alarming experience for the children. And you see their mums or their dads next to them, nerves in a completely unfamiliar environment. And our experience has been that actually this is a really good technique. It's good for children. It's good for their parents. It allows them to get in and out of hospital much quicker. And also it frees up time in theatre for other patients, for patients with hip fractures or indeed other children who are waiting prolonged periods of time to have their fracture surgery. So I really hope that you'll consider this excellent technique, which really can improve the care of our children and make life much easier for their parents as well. Thank you.